sectors as advocate and practitioner of sexual and reproductive healthcare rights and justice and women's health rights, working for over 40 years in sexual violence, midwifery, contraception, and safe abortion care. She has put her skills to use in the US, Mexico, Sierra Leone, Papua New Guinea, Uganda, South Sudan, Bangladesh, Myanmar, Uganda, India, Ukraine, Ethiopia, and most recently Sudan. She currently supports the emergency response in Darfur and East Sudan as an emergency health manager for MSF Operational Center Amsterdam. Today, Ruth will share with us a case study from Ukraine, highlighting older women experiencing loss, mental trauma, and absence of medical care. Thanks for being here.
Thanks, Elberg. So see, I am an old person. I'm 62, so it's by all the definitions we've heard, I definitely fall into the category. So been around for a little bit, but it's interesting in the conversations, like the language we use, the ideas of, quote, empowering older people. And I guess it's that question of, I think older people, right, we can empower ourselves. We just need people to get out of our way so that we can do that and have the space to define our own needs and our own solutions. And I think what we saw in Ukraine was a very classic example of when left alone, communities can really have amazing responses for themselves. They just need a little support from the outside. So go ahead. Oh, it's not working. So as MSF, we were in different locations in Ukraine, and I know you've talked a lot about the aging population, so I'm not going to talk much about that, but we were in different locations, and I'm going to focus on an area called Kharkiv Oblast, where we were providing care. In early 2022, Russia took over almost the entire oblast, except for the main city of Kharkiv, and MSF was in the city, and we were providing health care in metro stations. Most of the young families were fleeing with their children to other parts of Ukraine, to other parts of Europe, and older people or people who were unable to leave or unwilling to leave were the ones that were staying in the rural communities. At this point, we had no access to those rural communities because of Russian occupation, because of airstrikes, and because of insecurity. So we were providing care in the city. But the one thing we were trying to do is to support people in the rural communities with through these mutual aid organizations that had set up phone helplines to be able to provide prescriptive medication for people's chronic diseases. It was didn't serve a whole lot of people, but it was very popular for people to be able to get medication delivered through these networks to their homes. Next one. So in August of 2022, Ukraine had an offensive that took back much of Kharkiv Oblast, and we were in a really unique position where we were able to basically follow the Ukrainian armies in to access communities that had nobody from the outside in those communities throughout the whole occupation. So we saw this is a health center in one of the towns that we were providing mobile clinics. So we saw that the community suffered during that time. They had a lot of damaged buildings. There was, airstrikes from both sides because they were right on the front lines, and they, came together to turn their own cellars into shelters, to share food with each other, to share support for each other. So the population that stayed there, many of them had multiple diseases that they couldn't get medication for. They didn't have medical facilities, but they often had maybe a nurse in the community who would try to support as well as their local networks. But then there's also, of course, a lot of mental health issues, a lot of suffering and trauma based on experiences of violence, witnessing violence, as well as isolation, fear. Phone networks didn't work. People didn't know where their families were. They couldn't communicate outside. They couldn't travel freely. So people were very isolated. And those with disabilities already had increasing disabilities. Go ahead. So when we were able to get into these communities, our first stop was to see if we could find any health workers already in the communities. And of course, there were a lot of older nurses that were there who were trying to support. So we, in each of the communities we were worked in, we tried to get local nurses to help support us, to support the community. So it wasn't that we went in saying, oh, we're going to do an older people's healthcare project, but it was that we needed to pivot and do something that we weren't super familiar with because that was the population that were there. So the graph to the side, you can see very clearly the two last green lines are the shorter one is 40 to 49 years old, and then or sorry, 40 to 59, and then the tallest one. So you can see that the population was very much an older population that we took care of in this area. And so from August to December, we saw the 6,000 patients, and most of them were women, most of them were old. And hypertension and complications from hypertension was really the number one morbidity that we saw, as well as we had many mental health consultations, individual and group, and most of the consultations were related to anxiety, stress, witnessing violence. And we also tried to do these care of care workshops for these nurses and other groups in the community that were trying to do stuff to help support them because they were the ones taking care of their communities. So as a midwife, I focus on women's health, but usually on the healthcare for younger women, pregnancy, contraception, and all the things Elberg listed earlier. But then when we were looking at older women's health, we again came across things that we weren't usually dealing with in MSF and really actually not as comfortable dealing with. So for example, incontinence was a big issue for people, partly exacerbated by the living conditions, exacerbated by untreated hypertension, diabetes. So, but what did we have in our arsenal? We had adult diapers and Chuck's pads. But did women want adult diapers for if their incontinence was caused by pelvic organ prolapse, which was the case for a lot of people? No, they didn't want diapers. Who wants to wear a diaper? I certainly don't, right? So what we did was figure out that pessaries, where's our assisted technology person? We could call pessaries assisted technology for older women, because this was something that people were used to. They had used them a lot. Do you all know what a pessary is here? It's a small little round thing that you put in your vagina that lifts the uterus off the bladder because the prolapse of the uterus, because of weak muscles, things like that, puts pressure on the bladder, causes you to leak urine. And so it's something people were familiar with. So we found a local company to make us pessaries and started distributing pessaries. It was a very small little intervention, but when we talk about restoring dignity and finding out what communities want for themselves, this was a small example that was a success in that moment. Sexual and gender-based violence, we also saw as an issue. We weren't able to do as much of this as we would have liked to, but in this context, and actually UNFPA just came out with a report last month on voices from women of Ukraine that shows how intimate partner violence in particular has increased over the period, sexual violence as well, in any conflict setting we see. So this was something that we were able to do some care for older women in, and it's again not something that we're always used to, right? Our medical response for sexual violence looks at emergency contraception and things like that, which aren't necessarily the same issues that an older woman would have. So we were forced to pivot in this context to focus our interventions on an older population. Okay. The other thing we did with this population is look at how we can do advocacy and communications outside of the area to let people know what was happening to these older women, in particular in the community. So our comms, again, as MSF, we do a lot of advocacy and communications, but a lot of it is focused on the brutality of the war, what was happening. But we wanted to turn that around a little bit and focus on the endurance and the resilience of, in particularly older women and what they were doing to survive the war. So we did a lot of communications, TV, radio, publishing things. So that was another equal part of trying to restore, as MSF talks about, restoring dignity or allowing people to restore their own dignity by giving them the space to speak about their experience. And that's it. If anyone has any questions, I won't be around for the end panel.
Thanks, Ruth. Yes, does anyone have any questions at this point in time for Ruth? She'll be leaving soon, so if there's any questions, this is your chance.
Before the panel.
Or before the panel, yes. Anyone? Yes, Amrish. Oh, wait, sorry. We're getting lazy.
Great, thanks for your presentation. I think one of the angles that you also kind of really highlight is the, because earlier today we were kind of like discussing resource scarcity and the choices that we make and the increasingly difficult choices we'll have to make in different emergencies. And I think you kind of highlighted an example of, working with a local producer or something that I'm not sure it really was in their frame of, development or something I already had in the pipeline. I was wondering if you could elaborate a little bit more on how that worked and where you see other opportunities like that as well, or what lessons we could learn from that.
Yeah, I think even for the organization that MSF is, we are often very like stuck in our ways of working. And so we import medication and things. And so to do, let's say, local purchase of assisted devices, local purchase of medication, local purchase of something like this as pessaries, it's really not hard to do. It just takes us a bit outside our comfort zone and the box that we get into. And it takes people pushing for it and advocating for it from the inside that we can do it. I think another, let's say, issue that we had here is what people wanted from us initially was just medication. They didn't necessarily care about having a medical exam or having a clinic set up in their village, but they wanted to get their medication that those first visits we did. And there were medications in the country, right? They might not have been MSF medications. We, as MSF, we have these a bit old standard formularies, let's say, compared to other countries that have maybe 3 different hypertensive medication in one pill versus we have single drugs. Anyways, so there were issues around that too, that we wanted to try to use local medication versus the things that we had imported as MSF, because this is what people were used to. This is, people knew what their prescription was and people had a preference for that. So, but this was an internal issue that we had to overcome to see how we could get people the medication that they wanted versus what we usually have. So we talk about pivoting and being agile for emergencies, but then our systems sometimes hold us back from that.
Great, thanks. Is there another question? All for the back?
Yeah, to make you run out.
Hi, thank you so much for your presentation. It seems to have like a lot of hands-on experience, really on site, and you learn from it. Is there a system within the organization where you can use all the experience and all the things that you learned so that you can do better next time? What's your experience with it?
Do you work for MSF?
Who can think about it?
Are you, do you work for MSF? Okay. Yeah, no, it's a super good question, because we talk about lessons learned, right? In our prior presentation, he had a slide, lessons learned. I'm like, we should call them lessons, not learned, because do we ever actually learn them? No, because we do repeat a lot of mistakes. But for this, for example, we did we do reviews as an organization on interventions, and we do lessons for next time. And we try to change policy protocols and things like that when when things come up. But I do think that, for example, after Ukraine, I went to Ethiopia and to Tigray region, and our teams were doing these very busy clinics when the Tigray war had ended and there was access again, and there were clinics where hundreds and hundreds of people were going to. And so the teams decided, okay, let's prioritize children and pregnant women, but there were all these old people waiting. And so for me, having just come from the Ukraine, I was like, well, we should be taking some of the old people first, especially in their role in the community, their elders, they're respected, it's important for acceptance. And they're, have high needs. But it was interesting just for me personally to have a different view on that when I was in Ethiopia after Ukraine.
Super. Thank you so much, Ruth. Thank you.
Thanks, everybody.